Good morning, everyone. Thank you for joining us. Apologies, we are a couple of minutes late, but we just wanted to give a few moments of grace to ensure that everybody could be here with us. I welcome you here today to our 2025 Annual Educational Symposium for the Diabetes Across the Life course. Today's event is a virtual event. We have satellite sites in Alice Springs and Cairns where we have people in person joining us there with our teams who are hosting. And we have people joining from Zoom from across the country and also internationally. I think we've broken a record with today's registration numbers, with over 300 people registering, 150 in person across the 3 sites, and about 160 online. We've set it up so that everyone's cameras and microphones are switched off, but we do have moderators online, so please do pop your little things in the chat box and we'll make sure that we get to you over the course of the day. We've got moderators across the team who are on the ball doing their best job. For those of us here in Darwin, just a little bit of semi-boring housekeeping. We'll be keeping the front door here of the auditorium closed once the sessions have commenced. The toilets are in the foyer directly behind us over here in the auditorium. We appreciate people being prompt when returning to our sessions, just to ensure that we can stay on time and give everybody the appropriate amount of time allocated to stick to schedule. In the unlikely event of an emergency, please use the main entrance in the foyer over here and make your way outside to the muster point, which I believe is out behind us here. And there's an emergency exit over this way in this room if required. Okay, that's the boring stuff done. I would now like to introduce and welcome Maya Gregory. It's a great privilege to have you here this morning, Maya. Maya is a local Larrakia woman and is a member of the Kabillo clan group. Maya is joining us this morning to give us the welcome to country. Welcome, Maya. Thank you.
Menang gurugwa bachiwa, yana maya. Namule guru merajin benitba. Gwalwa guru merajin Gidangwa, Garmila, Ganbi, Nepo Islands, Benyelira, guru merajin Ananas Garagwa, Garmidira, Gwalwa, guru merajin 50 kilometers Durwa, Gimia. Tarmigiri, Gwarwa, Tarariki. Good morning, my name is Maya and I belong to the Kabillo family. I'm a proud Larrakia woman to my Gidang, Apaji, and my Alat, my mother, my grandfather, and my great-grandmother. I also want to acknowledge the ancestors and elders who have come before me, all Larrakia, Aboriginal and Torres Strait Islander people here today. We thank you all for the respect that you're showing to our peoples, the traditional custodians of the lands we stand on. The Larrakia Gulumerajin are the traditional owners and custodians of the lands, waters and seas of the Greater Darwin area, including Darwin Peninsula, Cox Peninsula and nearby islands. Us Larrakia people are known as saltwater people, but our country extends up to 50 kilometers inland. My late Apaji always taught us we are all connected to everything, to land, sea, animal, and to one another, and that we all have a shared responsibility to care for each other. The sea where we hunt for our food, the land where we gather our bush tucker medicine, and as you are living here and call Darwin your home, even if it's for a short moment, you now have this shared responsibility to care for everything as we have for generations. We have always welcomed people onto our land, just like I welcome you all here today. It is part of my privilege of health on myself and my elders working on the Galawa Taraniki, our land, the land of my ancestors. Thank you, Mamak.
Thanks so much, Maya. I'd now like to introduce Dr. Paul Burgess, who's a dual qualified public health physician and GP who's been working in the Northern Territory for over 20 years. Paul's currently the Acting Chief Health Officer for the Northern Territory Department of Health and has a strong interest in health systems, health service research and remote health workforce planning. We're really, really grateful to have you here with us today to officially welcome us to today's event. Thank you, Paul.
Thanks, Renae, and thank you also to Maya for a very generous welcome to country. And thank you also to the Gavillo family, who's taught my daughter everything she knows about basketball. So I feel very privileged and honoured to spend the last 25 years here on Larrakia country, and those welcome to countries always resonate with me very strongly and personally. Thank you very much for the honour and privilege of opening the symposium today. I think I want to acknowledge that we are joined online by people from other First Nations countries in Australia, but also internationally. And today is actually the 14th annual education symposium about diabetes across the life course. It's been a wonderful initiative that we have been part of as the Northern Territory Department of Health, partnering with researchers to bring the best knowledge into practice, and hopefully a bit of vice versa as well. Last week, I was camping on the Finke River in Central Australia, and I was shocked to realise it was 30 years since I first came to the Northern Territory. And that first year in 1995, as a very green medical student doing diabetes survey work in Central Australia, I was reflecting on what changes I've seen over 30 years. And there is a segue to coming to today's theme, so just bear with me for a couple of moments. In 1995, when I started, it's hard to describe. I think we're still on paper records. I think it's probably the time of chaos, really. I think it was the first appreciation of the enormous burden of diabetes increasing, particularly in Central Australia. I remember Professor Robert McDermott, who many of you will know in the room, telling me in 1995 that diabetes was worse than HIV because the life expectancy from diagnosis through to death was less than 10 years, and HIV had better outcomes. That really struck to me as a problem that needed some really good thinking to do better. I think in the early 2000s to 2005, we had electronic health records, which came in, and we got extremely excited about, for the first time, having information, able to have recall lists, able to have registers of patients with diabetes, and start getting a bit more organised, start coordinating activity between multiple health providers to try and provide wraparound holistic care for diabetes patients. I think we saw some really important innovations in the Northern Territory that influenced the country. We were the first jurisdiction to have a chronic conditions strategy that influenced then the Commonwealth to have a national chronic condition strategy. So we've had a lot of lean innovation, a lot of creative thinking, and a lot of fantastic clinicians and thinkers have really led us to lead the nation in many ways in those early days, dealing with diabetes and other chronic conditions. From about 2005 to about 2020, we certainly had a very strong push for data-driven approaches, really using data for quality improvement, to manage populations, to make sure that nobody was missing out on care. I think the downside of being very strongly data-driven is we end up doing something to people and not with people, and that was a real lesson. From about 2020, with the pandemic, we saw a major disruption to healthcare delivery, particularly in remote primary healthcare. We saw patients no longer engaging in primary healthcare. We saw diabetes control deteriorate very rapidly. And about the same time, collaborating with Renae Kirkham, we were doing some really innovative research around perhaps the most sensible thing we could have done a few decades earlier, about sitting down with Aboriginal communities and asking them what quality care looks like. And when we looked at the results of that piece of work, it came through very strongly that what quality care looks like was Aboriginal-led, was Aboriginal facilitated, and it was a very supportive model of care that was based on Aboriginal principles of caring for each other, love and respect. And there's words in Aboriginal languages for that. And what a beautiful strength-based approach to healthcare. So we're seeing that now in terms of some early, you'll hear during today's program, the importance of engaging with communities and having community-led partnerships. And perhaps we could paraphrase Winston Churchill, which is, he often is misquoted, but I'll misquote him again today, that you can always trust researchers and healthcare professionals to do the right thing, but only after they've tried everything else first. So I think we're in that position now where actually we've done the hard yards, we've we've sat down deeply and listened, and I think the program today is a wonderful program illustrating the great benefits, but also joy that can come from actually legitimate partnership with our First Nations communities to develop systems they want to get the outcomes that they want as well. So with that, I really am delighted with the program today, and the community perspective, I'm sure, will come through very, very strong. It's my absolute honour and privilege to open the meeting today, and I'd like to hand over now to Renae Kirkham, leader of the Diabetes Across the Life Course program, Valda Wallace and Dr. Darr, the Partnership of Senior First Nations Leadership. Thanks very much. Enjoy your day.
Thank you so much, Paul. Okay, just bear with me. So before I commence my brief talk this morning, I just want to acknowledge myself, the Larrakia people of the land we're meeting on today here in Darwin, and also the Aranda people of Alice Springs and the Gamoy peoples of Cairns and surrounding lobs. I also pay my respects to elders past, present and emerging, and those First Nations people who are joining us online today. The theme of this year's symposium, From Research to Change, the impact of community-led partnerships in diabetes, was developed in reflection of the work we do and the longevity required to ensure that we achieve important and meaningful research impact. It provides us an opportunity within the partnership to showcase and think more deeply about the ways that we can continue to grow and build, incorporating community voices and priorities into the research that we do in partnership with our key stakeholders, that is community-led. Our panel discussions later this morning will provide a really good opportunity to reflect on some of the work being done, some of the key principles and examples of what it means to do this well, and also for opportunities to continue to grow. Our program has a really strong focus on two of the key program areas within the partnership. So today that is youth type 2 diabetes and diabetes in pregnancy, and we're really fortunate and excited to have two really incredible keynote speakers joining us this morning to deliver on some really important work that they're involved in and leading in their respective areas. So Professor Brandy Wicklow, who's joining us here from Canada, and also Associate Professor Jackie Boyle. There she is over there, who's joining us from Melbourne. So it's really wonderful to have you both here in person, because often we aren't privileged enough to have that. We have people joining online, so thank you. Every year, our evaluation feedback post our symposium highly rates sessions that provide really practical and clinical solutions to the management of diabetes in our remote Northern Australian context. And so this afternoon's panel discussions are really tailored around these requests, again focusing on youth type 2 diabetes and diabetes in pregnancy. And we have a really fantastic lineup of panel members who will bring a wealth of knowledge and expertise to enrich those conversations and discussions. Many of you have seen this slide, but I am conscious that we have a really high number of participants today, so it's important just to recap on why it is that we're here and why it is that we do the work we do. So the vision of the partnership is to work in partnership with Aboriginal and Torres Strait Islander people, primary healthcare and community-controlled organisations to break the cycle of type 2 diabetes and related conditions. We have three key priorities. The first is the prevention and improved management of obesity and diabetes across the life course. The second is around strengthening community engagement in a life course approach to diabetes, focusing on preconception, pregnancy and youth. And the third is around strengthening the Aboriginal and Torres Strait Islander community-based workforce in diabetes. And I always like to emphasise that we're not talking only about the health-based workforce, we're talking about the community-based workforce, because there are some incredible people that are in the community, and when we listen to people's voices, we know that it doesn't all need to sit in the clinic, nor should it. We need to really leverage on the expertise of the incredible people who are our First Nations community members. I guess I just also want to take a moment to reflect on some of the findings that have come out of the partnership over the last few years, which have really highlighted the devastating news that we have the highest prevalence of type 2 diabetes in the Northern Territory as reported in the world. So just to reiterate, 1 in 3 adults are Aboriginal and Torres Strait Islander adults are living with type 2 diabetes, with 40% of adults in Central Australia communities having a diagnosis of type 2. We've also observed a higher prevalence of diabetes among Aboriginal women as opposed to men, with substantial growth that has occurred in the prevalence of women diagnosed with type 2 diabetes prior to pregnancy. In Central Australia, 1 in 70 young people under the age of 25 have a diagnosis of type 2 diabetes, which is the highest rate in the world, and it's 20 times higher than that recorded for non-First Nations youth. That is why we have a really big, amazing team who work tirelessly in collaboration with our external stakeholders and partners to try and break the cycle of type 2 diabetes and related conditions. We currently employ 51 staff across Northern Australia, with offices in Alice Springs, Cairns, Katherine and Darwin, and 25 of our staff are First Nations. I really just want to take a moment to acknowledge the tireless work of the staff and students of our partnership, who are critical to all of our work aiming to address and break the cycle of type 2 diabetes. A common term that we are seeing in the research world is co-design. And while this is really critical, and it's a really critical approach informing and underpinning a lot of the methodologies that we use in much of the research that we now do within the partnership, the term co-develop is one that also really resonates very strongly when it comes to the work that we do in and across the partnership. I would argue that co-develop really reflects the longevity of building meaningful partnerships and designing and implementing meaningful work. It also acknowledges our First Nations team, who have such a wealth of knowledge and experience that is integral to all of the work that we do. This is particularly pertinent to ensuring that we continue to build considerations of the social and cultural determinants of health into all stages of our research. Listening and working with our First Nations staff and team members, who are also members of the community, is the first step that we take within the partnership to ensure the work that we do is meaningful and impactful. Just a brief update. Given the size of our group, we now have a senior leadership group who provide oversight to the direction and work that we're doing. So I just wanted to introduce you all to members of this group. We've got Miss Valda Wallace, who is part of our senior First Nations leadership, who will be coming up in a moment to introduce herself. Dr. Jenifer Darr, who's also a member of our senior First Nations leadership. Dr. Diana Mackay, who's the partnership deputy lead, shared with Dr. Angela Titmus. Dr. Matthew Hare, who is the deputy lead of our Wellbeing and Preventable Chronic Disease division within Menzies, and also Mr. Anthony Gupta, who's the program manager of the partnership. On that note, I would just like to introduce you officially to Val and Jen, who will come up and speak for a few minutes.
Good morning, everyone. And Maya, thank you for that wonderful welcome. I spent a lovely 23 years living in Darwin in another life, and always feel welcomed and privileged to be back here. I'm Val Wallace. I actually live in Cairns and have popped up here for a visit. I'm a Kookaburra woman, and my father's country lies to the west of Ingham in Queensland. And I also acknowledge my South Sea Islander, German, Chinese, and European heritage. I grew up in the Atherton Tablelands and have ties to the Torres Strait Islander communities through family, friends, and work colleagues. My work background spans over 45 years and includes health, policing, family support, and academia and research. I have experience in qualitative research, community engagement, Aboriginal and Torres Strait Islander protocols, and research ethics. And I believe that despite the challenges facing Aboriginal and Torres Strait Islander peoples, our knowledges, strong cultural beliefs, strengths and resilience continue to contribute to innovation and research, community development, provision of appropriate services, and improved health and educational outcomes. Working towards improved outcomes drives my passion for working with my people. I feel really privileged to be working with the Diabetes Across the LIFECOURSE team, as it is a true partnership where the knowledge, skills and experience of our non-Indigenous staff melds with the hundreds of years of cultural knowledge that our Aboriginal and Torres Strait Islander staff bring to this space that we call the partnership. Jen and I are here to add to that knowledge and, along with our First Nations staff, give voice to our people and community. I'll pass it to Jen.
Thank you, Val. Thank you, Renae. Good morning, everyone. So I am a Ewing Vanuatu woman and bred, born and raised in Far North Queensland in a place called Ayr. Worked as a nurse primarily, then moved sideways into management and managing Aboriginal community controlled health services for a number of years, where I realised that the accreditation standards that they were applying weren't fit for purpose. So that launched me into doing a PhD. I graduated from JCU in December last year and am now working with Menzies in the partnership. So I bring to this space that level of experience, and my expertise lies in systems thinking, design and implementation. So both Val and I share the one role, and so what we want to leave here is we want to be a value add into this space and leave something of value behind. So that's me in a nutshell. Thank you.
Thank you both very much. It is definitely, we're very grateful to have you have joined the team and to provide all of your knowledge and insights that have been guiding us and will continue to guide us in the good work that we do. Just some of you may have seen this slide, but I just want to come back to the theme of today around from research to change and the impact of community-led partnerships in diabetes. It's really important to highlight that public health impact begins when programs are sustained. And the data tells us that this is takes approximately 10 years. So the most sustained impact of our work in the Diabetes Across the LIFECOURSE partnership supports this theory. We have 3 of our key project areas, all of which were established by Professor Louise Maple-Brown quite some time ago, over 10 years ago, that have been sustained by various funding streams and led by different members of our team since the inception of the partnership in 2011. And I just wanted to give a quick overview of what they are and what some of the impacts of that work have been over that time, to really highlight and demonstrate that, yes, it does take time. B, it takes a lot of hard work from not only people here based at Menzies, but also, probably more importantly, people in the community who are committed to the work that we're doing, and also the partners and key stakeholders who are absolutely instrumental in supporting and implementing and championing the work that we do and continue to do. This is a photo from the 2020 NT Diabetes Summit. And I think I just wanted to demonstrate that the collaborations and the people and the stakeholders, it is vast, there are many. This is a snapshot of some of those people, some of whom are in the room and online. But I also just want to reflect on the fact that meetings like today are really an opportunity to celebrate partnerships like this and the impact of our collaborative work. Meetings like this foster the conversations that we need to help to develop and guide our work now and into the future. And not only do we have partners that are in this photo, but some that aren't included, given this was NT focus only, are some of our key partners from across far north Queensland, including Gurney Yallamaka, Cairns Diabetes Centre and Wollongong. I just want to make sure that I acknowledge those really important partners as well who've been around for a long time supporting our work. So going back to the three key program areas within the partnership, Pandora, I think everybody has heard about Pandora. It's one of our flagship programs. It was established in 2012, supported by an HMRC project grant, where the key aims at that point were to understand the impact of diabetes in pregnancy on offspring. It was followed up by a subsequent wave, wave 1, which went from 2016 to 2018, with the aims of that particular wave to understand gestational diabetes after type 2 diabetes and also the growth and development of children. Then we had another wave from 2019 to 24. And the key aims of this work were to understand gestational diabetes after type 2, cardiometabolic outcomes, as well as the growth and diabetes risk for children. Just want to flag that Louise Maple-Brown established and led this work up until this point. Following that, we have had recent success with obtaining more funding for wave 3, which is underway from now until 2030. And the key aims of this work are to continue to understand and deepen what we aimed to set out to achieve in the aim 2. And this work is now being led by Dr. Anna Wood. Just to touch on and reflect on some of the key impacts from Pandora. This is not all of them, but it's some. So the work in this stream has highlighted the importance of close postpartum follow-up after pregnancy and incorporated postpartum glucose monitoring into clinical practice. It's also highlighted the very high rates of progression of type 2 to GDM among Aboriginal women, with maternal weight being a critical modifiable risk factor. And this led to the establishment of the first weight management clinic here in the Northern Territory, which is led by Dr. Anna Wood. And it was the first study to report growth trajectories of children born to women with type 2, and to understand what this means for long-term cardiometabolic risk will be one of the key aims of the next follow-up wave, wave 3. The next key stream of work that we undertake is within diabetes in pregnancy. So this again started in 2012 by Louise Maple-Brown, with the first aims to really establish a diabetes in pregnancy clinical register in the Northern Territory and to evaluate models of care. That work continued with the NNHLRC GACD grant, which led us up to 2020, with some of the key aims to continue to build the clinical register in the Northern Territory, but also to establish it in far north Queensland. That happened in 2016, and also to continue to enhance models of care, not only in the Northern Territory, but now also refocusing some of our work to include far north Queensland. Work that has followed since then has been co-design work, which really, I guess there was a little bit of qualitative work going on in the background. That's sort of when I came around. I was the first qualitative researcher in the group, and that some of the early work that I led in that space really highlighted and emphasised women's experiences of living with diabetes in pregnancy, and what were some of the other things that we needed to be considering, not only well, obviously to address their needs, but we'd had a real systems focus and a models of care focus. And so that had been really driven by the data, the health centre data, and also what health professionals were telling us. But by having this other lens, we started to more deeply understand what the needs of women in the community were. And so that really led to this next phase of work, which was around co-designing and evaluating strategies to reduce the intergenerational risk of diabetes. So really incorporating women and communities' perspectives into doing things that work for them in the best way possible. And we'll hear a little bit more about that work later this morning. It'll be presented by Diana and Wallace. So this work was led by Louise from 2012, and then more recently, Diana Mackay has taken leadership of the co-design project. We have another program in this space, Integrated Care, which has recently received funding for the next 5 years. And the main aims of this piece of work is to co-design, implement and evaluate innovative technology for diabetes in pregnancy care. And this piece of work is being led by Dr. Matt Hare, who's another key member of our partnership. Just want to flag here, we have submitted another grant to follow up some of this work. So, you know, some of it's coming to an end, but we are we are very keen and dedicated to continue our efforts in this space, picking up on some of the recommendations that are coming out of the co-design work, which is really about how is it that we can continue to develop and evaluate community support models for First Nations women and also youth. There's been a real crossover in this space, which makes a lot of sense because the young people are mothers, and there's some lovely synergies. So it's great to be bringing that all together. So we'll see what happens, but be rest assured that we'll be continuing to work to continue in our work in this area. And also, I just wanted to flag. Without losing, I've just been told I've got 5 minutes left, so thanks guys, now you've thrown me off my train of thought. I just wanted to flag it. I think that the diabetes in pregnancy story is a really important one to demonstrate how we've transitioned really from thinking about health systems from a particular lens to now really including community voices and perspectives, to thinking about how do we make changes there. Some of the key impacts in diabetes in pregnancy to date, we've had some key health systems changes that have happened. So an increased uptake of first trimester glucose screening in the Northern Territory for women with diabetes in pregnancy risk factors. We've been able to embed and amend hospital discharge summaries in partnership with our key partners. And we've also been able to inform the updated screening guidelines for diabetes in pregnancy, which have been released by the Australasian Diabetes and Pregnancy Society. And we've also been able to increase awareness of diabetes in pregnancy for women, community, and also health professionals, and improve confidence and knowledge in management of DIP. Quickly, Youth Type 2 Diabetes, our program of work, that started in 2019, well, thereabouts, really with some small seeding grants to understand really what were the needs and experiences of Aboriginal and Torres Strait Islander young people who had type 2 diabetes. That then led to a bigger program of work to collaboratively develop and evaluate enhanced support for young First Nations people living with type 2 diabetes across Northern Australia. That was led by Louise and I. And then the follow-up piece of work there is looking at, it's the Inspire project, looking to implement and evaluate culturally safe models of care with a focus on mental health, wellbeing and improved diabetes management. All of this work also fed into another project, Doing It Together, which is led by Angela Titmus, which is really looking at co-designing, piloting and evaluating strengths-based peer-led approaches to support young people with type 2. And we've got Michelle and Waylon who will be presenting on that project later this morning. And again, this is the same project, but I just wanted to highlight that there's a lot of crossover there, how we're coming together between diabetes in pregnancy and youth now, which is exciting. This is just a snapshot of some of the key findings and potential impact that are coming out of our youth type 2 work. So essentially, these are some key areas that we've identified young people would like clinicians and other support people to understand how to better offer more appropriate support to them in their diabetes management journey. I think some of the key impact in the youth type 2 diabetes space has really been around the development of screening and management pathways. I think a really important one there is that our partnerships, particularly with the NT Diabetes Network, led to the development of screening pathways for children and youth at risk of type 2, which were then taken up by the Australian and New Zealand guidelines in 2020, and that work has since evolved and been taken up, which is really exciting, particularly given that the more recent ANZ guidelines include intergenerational risk, social determinants, mental health, with a larger focus on holistic support and management strategies. The last piece of work that just highlights a bit of longevity is the work that we're doing in youth type 2 diabetes prevention. So this includes work we were funded to adapt the tribal turning point in Central Australia, and then we've more recently been able to trial the implementation of that adapted program. Just to flag, I'm running out of time, that we've had a number of key research highlights across the broad spectrum of the work that we do since our last symposium. And we've had a publication this week actually in the Australian and New Zealand Journal of Public Health, really highlighting the importance the role of schools can play in as a key setting for supporting the health and wellbeing of those living with type 2 diabetes. And I just want to flag that this work, I think, really fits in with the theme of today because it was informed by the lived experiences of First Nations youth living in the top end, and it calls for school-wide measures to address diabetes stigma, nutrition and targeted support for the clinical management of type 2 among youth. We've had a couple of really important successes to celebrate. Dr. Mary Wicks submitted her PhD recently. We've had Dr. Diana Mackay and Dr. Anna have their PhDs awarded, and we'll be hearing from both of those soon. And we've also had Corinne Butler and Kim Martin have their master's projects completed and awarded. So it was a race to the end. Events like today provide us with a real opportunity to not only update you of the work that we're doing within the partnership, celebrating the combined efforts of all of us involved, but also to showcase other relevant research initiatives and findings nationally and internationally that we can learn from. It also provides us a really important opportunity for us to connect and to reconnect with each other to ensure that we continue our combined efforts to break the intergenerational cycle of type 2 diabetes and related conditions. And here's the QR code which will lead you to our website, which provides all of the information about the work that we're doing, the projects that we lead, and also a lot of the resources and publications that are available for you to access. Now we'll get to the really exciting part. I would like to introduce you all to Professor Brandy Wicklow, who I mentioned is joining us today in person from Winnipeg, Manitoba in Canada. Brandy's work is across the University of Manitoba. She's a clinician researcher at the Children's Hospital Research Institute of Manitoba. She's a paediatric endocrinologist and the head of the section of paediatric endocrinology and metabolism. It's a lot of hats, Brandy. Professor Wicklow's clinical career focuses on healthcare provision to underserviced children and youth, including outreach type 2 diabetes, subspecialty care to Indigenous children living on reserve in northern communities in Canada. Her clinical research focuses on the intergenerational and early life determinants of type 2 diabetes and renal disease in children and adolescents, with a particular interest in the psychological, economic and social and structural impacts on the holistic health of children living with diabetes. There are many synergies, as you'll see, of the work that Brandy's leading in Canada and what we're doing here in the youth type 2 diabetes space. We're really lucky to have Brandy here in Darwin with us, welcoming you back after many years since your last trip, and we look forward to hearing about what you're up to in your neck of the woods. Come up, Brandy.
Hello, thank you very much for having me. I feel very honored to come and work. What an incredible body of work you're doing. And Louise has been a friend and mentor of mine as I have gone through the journey myself in my own country of Canada. And so I appreciate the welcome to your country, and certainly it's beautiful. And I've had some time to walk around in the last day or so. I don't have anything to disclose. I would like to acknowledge where I come from because we work in partnership with First Nations people in Treaty 1 territory in Manitoba, which is the homeland of the Anishinaabe, Innisfinnik, Denison, Iote, and the homeland of the Red River Métis. And we work in partnership to sort of talk about the truths of what has happened after colonization in our country. And so some of the more disappointing slides come up front, but we do find it's very important to talk about the truth and what colonization has done to a body of people so that we can advocate for improvements in care and health outcomes. And then a little bit about the reconciliation in terms of my own personal journey towards reconciliation in terms of training Indigenous physicians and researchers in community and working in partnership with our team. So this is where I come from, Manitoba. I'm right smack dab in the middle of Canada. Our population is just over 1 million people, and in Winnipeg it's just about 800,000 people, of which the Indigenous population makes up just about a third. And you can see there that the large population of Indigenous people are First Nations, with some Inuit people and Métis people as well, who are the original custodians of our lands. I'm going to start just by introducing you to a mentor of mine. This is Mary Jane Wood. Mary Jane Wood I met back when I came to Winnipeg in 2010. This is her family. And used by permission, obviously. And this is Mary Jane's son, Matthew. And I've been talking about Matthew for a long time, but this family has been on this journey with me for a long time. Matthew is 9 in this picture, and he came down with Mary Jane and the rest of her family to see us in the diabetes clinic. And typically, we don't take pictures of all of the families that we see in diabetes clinics, so there's got to be something special about Mary Jane and her family, and certainly there was. So Mary Jane was actually one of the first children to be diagnosed with type 2 diabetes in our country, and had a long history of clinical partnership with my mentor, Heather Dean. And so this is pretty typical. Matthew comes, he got picked up by his kukum or his grandmother in community because they test all of the children. They have testers at home often. And he had a sort of a gunky toenail, asymptomatic otherwise, and was seen in the nursing station, where they did a random blood sugar, which you can see is elevated, a significant metabolic decompensation with an A1C of over 12%, and was acidotic. So flown down to Winnipeg because there aren't hospitals in community to take care of these kids, which is a shared problem, I think, for a lot of northern communities. So, you know, Matthew presented quite typically. This is some of the early work we did across Canada, looking to see what do these kids look like, because we do have a proportion of First Nations kids who have type 1 diabetes, and how do we decide the care plan and the care map for these kids when they get diagnosed? And so a large majority are actually asymptomatic. I don't know if you can, a large majority are actually asymptomatic. Some will have that sort of darkening of the skin, which is quite typical of insulin resistance. a large proportion of our kids, quite unfortunately, are ketotic or come to Winnipeg with diabetic ketoacidosis. This is a screening issue and a resource issue up in our communities that we are trying to navigate as we improve healthcare. You can see the higher rates of dyslipidemia and hypertension at the time of diagnosis and albuminuria. Most are antibody negative, although not all, and some have monogenic diabetes diagnosed in the first 2 years of us following them, but it's a fairly small proportion. So what is the magnitude of the issue in my country? So this is the Canadian incidence. So you can see that First Nations children are disproportionately affected. I think that's a worldwide phenomenon, and it's no different in Manitoba. It's about a 41% increase over the last decade that we've seen. Interestingly, a larger increase has happened in non-First Nations individuals in our country. So a 75% increase in a lot of refugee populations, Filipino populations in Manitoba. So there's a large increase across the board in different ethnicities of type 2 diabetes. The question really is why, because things haven't changed that much in the last 10 years. Certainly in our communities, infrastructure has been the same, if anything, hopefully improving. And so, you know, in discussions with a lot of our elders, there's a lot of talk about traditional foods returning to the lands for activities and traditional games, and concerns about pollutants in the water. So the polluting of lands that has caused ill health in our country, and ill health to the children. And so how do we start to look at levels of mercury and arsenic in our populations? And then there's a question about how much of this is genetics. And I'm not going to tell you the HNF1 alpha story. What I'll tell you is that it actually was probably a very good polymorphism when people ate diets off the land, and it actually prevented them from having hyperglycemia. And it has caused problems related to colonization of Western-based foods. And some epigenetics work that we have done has suggested that this might be part of the answer, which I'll get to. This is the Manitoba incidence. So you can see at the top, this is First Nations children have gone from 72 per 100,000 to 120 per 100,000. So we also are struggling with the increase in this population. This is all children in Manitoba, and then this bottom line is the increase in non-Indigenous children in our province, which has also doubled from 3.1 to 7.7 over time. So 50% more children are diagnosed compared to about 10 years ago, despite the fact that we've been doing this work for 10 years. So it goes to show you change is slow, but that patience and progress will come if we work in partnership. Our First Nations children are more likely to develop diabetes, as I said. This is some of Angela's work. I know you've already shown some of it, but I thought I would just share that we look very similar in our two countries, probably not because of just the fact that we are sort of from British colonies, but the context of colonization and the shared history that we have, I think has related us in a lot of these poor health outcomes. So we look very similar. Higher rates in females, that's pretty much a worldwide thing. Higher in the adolescent ages, although the youngest diagnosed at 4.4 years here, and we've done a case series of kids under 5 that are diagnosed in Winnipeg, and that is a large body of children that we are starting to see. Median A1C also higher, and this speaks to the difficulties of healthcare resourcing in the north and the ability to run effective screening programs early for kids, especially kids that are at higher risk, which is part of one of the studies that we are looking at up in Winnipeg. I think this is part of the reason why we are seeing increased incidences of type 2 diabetes in kids over the last 10 years. So if nothing else has changed, and we have had the same technology and the same infrastructure issues, then what is it that's driving this? And I think it's type 2 diabetes in pregnancy. I think when we first identified type 2 diabetes in communities, it was the first 12, mostly women, and then those women went to have their children children who then developed type 2 diabetes and then went to have their children who then went to develop type 2 diabetes, and really speaks to this life cycle. And so the problem with Western-based medicine that all of my First Nations partners will tell me, and knowledge keepers, is that we work in silos. So I do pediatrics, and then someone does pregnancy-based care, and then someone does adult care, and never shall we meet and work together on some of these problems. And it takes these kind of partnerships and partnerships across what are historically medical boundaries to improve the lives of these. So I spend a lot of time now in prenatal clinics as a pediatrician, and I spend a lot of time in diabetes and pregnancy clinics to try and get a bit of a more holistic and family-based approach to type 2 diabetes in kids. So let me go back to Matthew. So this is one of the very first publications of type 2 diabetes in children. This is 1992, done by Heather Dean, my mentor, obviously with the very old language in terms of this. You can tell this is a very old publication. But here's Mary Jane. So Mary Jane's patient 12. Obviously female. She was diagnosed when she was 11.8 years of age. So that's before she had any of her kids. And you could argue sort of very early on in the pubertal stages of a young woman. Her BMI was 23 at the time, so not what we would actually call obese, which is a cutoff of 30 as an adult, probably close to overweight and obese in terms of Z scores. You can see her serum glucose was quite high. And her A1C was 10.7%. So she had been diagnosed also with quite significant childhood onset type 2 diabetes. What is interesting about Mary Jane is that Matthew is the first kid I met, but Charlotte here, who's on Anthony's lap, who is her eldest child and son. Charlotte came to us in clinic when she was about 8 years old, diagnosed with type 2 diabetes. And then Genevieve is here on Mary Jane's lap. And Genevieve, we started to follow when she was 9 years old and got diagnosed with type 2 diabetes. And then in Mary Jane's belly is Savannah. So you can't see her yet, but I do have a picture of her. And Savannah developed her type 2 diabetes at 8 years of age, which is why I said, this is a woman who really helped mentor me, because she said to me things like, you know, Brandy, this is most of my family and I don't understand. And is this just because I'm First Nations? Is it because I had diabetes and it's so strong in my family? Is it genetic? Can you help me to sort out what's happening to my family? So one of the very first studies I did was to look and see how much of this is sort of First Nations in terms of the intergenerational trauma in a family, and how much of this is type 2 diabetes exposure in utero. So this is a Manitoba population-based study. So we took all the births in Manitoba and paired them with the offspring, and just one mom and one offspring. So if mom had several offsprings, we just took her first. And you can see we did First Nations offspring versus non-First Nations offspring. And then we linked the population-based data to our clinical registry. So we have been fortunate to collect clinical data on every child who comes through our clinic, and we're a one-stop shop for the province. So we are the only people who do subspecialty diabetes care in all of Manitoba and part of Northwestern Ontario. So our capture is quite good. And so we could take out children who we knew had type 1 diabetes and parents we knew had type 1 diabetes. So we're truly just looking at type 2 diabetes. And this was the answers that we got. So I think what is most remarkable that you can see probably is that this is First Nations women with type 2 diabetes and the risk to their children developing type 2 diabetes by the time they're 30 years of age. So here is cumulative incidence, 5%. You can see it goes up to about 22% risk. And here is from birth to 30 years of age. You can see the numbers here get small near the end of this cohort follow-up period. But certainly there is a difference between children from First Nations mothers exposed to type 2 and children from First Nations mothers who have gestational diabetes. So there's a clear distinction about that first trimester that seems to impart much higher risk than moms who have gestational diabetes. And then you can see Non-First Nations mothers with type 2 diabetes, I think that's the other interesting thing. Their kids seem to be at higher risk than First Nations mothers without diabetes. So certainly type 2 diabetes seems to be the strongest driver of risk to children. And I think that's probably why we continue to see this increase over time. So what do we know? If mom didn't have diabetes, then maybe 1 out of 10 of her kids would develop type 2 diabetes, most likely female, because that is still predominant in all of the different studies that we've looked at. Gestational diabetes, that risk doubles, but type 2 diabetes, it significantly increases. And the question is, 1, how do we change it? And 2, why is this happening? And so one of the studies that we looked at was timing of onset of the type 2 diabetes. And so if mom doesn't have diabetes, then as you've seen, the average age is teenage years, which makes sense because that is when we have pubertal insulin resistance and the greater risk of developing type 2 diabetes, much like pregnancy. So pregnancy and puberty are very similar in their risk of developing sort of metabolic decline. Gestational diabetes, those kids are younger. But type 2 diabetes, now you no longer need puberty. And so there's something about these kids that don't need that second pressure of puberty, and they don't really need that second pressure of significant obesity either. So there's something happening in utero that it seems to be pre-programmed these children that we need to focus on in terms of change. And so that is one of the studies we're running out of Winnipeg called the Next Generation Study, which is following moms through pregnancy and their offspring, and looking at sort of that period, postnatal period of change where we can impact and improve these outcomes for the kids. I just want to be clear that ethnicity is a proxy measure for us, right? And so when I talk about First Nations being a risk factor, I don't mean First Nations, right? So I think that what we need to understand is this is what First Nations means in Canada, right? It means loss of culture and loss of language and a lot of really terrible things. Which causes really bad health outcomes for people in our country and in our province. Sometimes this happens to me, so we'll move on. But just to be clear, that's what we're talking about. Okay. Some more slides that are less happy, and then I'll get to some happy slides. These are the complications of diabetes in Manitoba children. This is an old study that was done by my friend Alison Darr and colleague Alison Darr, who's a nephrologist who looked at the risk of poor outcomes compared to type 1 diabetes. These are survival curves. So this is 100% survival, meaning no retinopathy at all. And then this is 100% getting retinopathy. And you can see the clear distinction by age of outcomes, but probably the most important really is driven by nephropathy. So if you're diagnosed with type 1 diabetes, then at about 25 years of age, maybe 10% are on dialysis. But if you're diagnosed by type 2 diabetes, by 20 years after the onset of your diabetes, about 70% are on dialysis. So we're talking about kids that are 30. And so in our northern communities we go to, although there's not running water in all the houses, there is an 8-bed dialysis unit run by our federal government. So this is work that Liz and I did, because a lot of the argument is, well, it's not a more aggressive disease than it is in adults. Kids just live with it longer, right? If you're diagnosed with 10, you just live with your disease longer than if you were diagnosed with 40, but really the risk is the same. And so this matched for duration of diabetes and looked at what does it really look like for type 2 diabetes in youth and type 2 diabetes in adults. That's what this was driven by. Compared to diabetes-free youth, which were matched for ethnicity, community, and also adiposity, and then looked at type 1 youth. And what I think is obvious, this isn't published yet, so the graphs aren't beautiful, but I think what's really obvious is that there is certainly a significant increase in time and development of chronic renal disease and end-stage renal failure in our kids with type 2 that needs to be addressed. And part of the question is, well, is this also born out of exposure to type 2 diabetes in utero? Is this a pregnancy problem that we are seeing later on in life? And although not as striking as the data that I showed you for cumulative incidence, this is the same kind of graph over years after birth, but this one goes till 40. You can see that there also seems to be some early programming based on type 2 diabetes exposure in utero in terms of kidney outcomes. So we spend a lot of time sitting with kids to say, so things aren't great, and there's a lot of diabetes in your communities, and there's a lot of renal outcomes that are poor related to that, and how do we work with you to make it better? And they said, yeah, so there's issues for me, just understanding my disease and having the support that I need, but also my family structure and infrastructure. And if my mom is on dialysis and I'm living between my aunties, which often communities do, my aunties and my Kirkhams and my mom when she's in town, but also, you know, we have a lot of health issues. It's hard. It is hard because there isn't one single sort of family unit that's responsible for it. And the kids end up sort of carrying their stuff from home to home, which obviously is a problem. Schools are a problem in Canada. They don't support kids with type 2 diabetes very, very well. They're often actually not open. There's a lot of issues with water and other infrastructure problems with the schools, and then communities and the larger issue for society. So that's how we built the iCare cohort in partnership with the kids. So here's Matthew. So this is much older than 9 now. And so we go up to community and meet with Matthew, and then go on the radio and the TV stations and to the schools to talk to people about type 2. And Matthew shares his story about type 2 to try and help kids be empowered to feel more comfortable to check their sugars and do other things. This is Alison Darr, the nephrologist that I work with. Obviously, that's me. And with the kids, we looked at sort of how do we build family and community into what otherwise was very much a biological model of illness instead of a holistic model of health. Hard to wrap your head around that when you're trained as a doctor, and we deal in disease, as opposed to trained as somebody who deals in health, but we're learning a lot. So we spend a lot of time up north. This is what our communities look like. I think we get a little bit more of the white stuff than you probably see. This is a flying community where Matthew lives. This is St. Teresa Point. The hovercraft is what gets us across and frees up in breakup season. Otherwise, the water freezes and there's ice roads, and if you've seen ice roads truckers, that's where they go to. Those are the communities. This is me up in here. This is all my gear that I am dragging over to do screening and testing in communities. So that's how we get our stuff there. This is me pretending to be happy. I hate helicopter rides. So what have we learned? So this is sort of 5 years of data in one slide, but this is what we've learned from the iCare cohort so far. You can see that there's a high rate of dysglycemia in the kids. Almost half of them have daytime or nocturnal hypertension. We do ABPMs so that we can catch the nocturnal only hypertension, of which we have a significant amount. There's a lot of mental health issues related to lower socioeconomic status, and there's a lot of issues with food security, which are a problem when we're trying to prescribe medications that require you to eat at a certain amount of time. And so there's a lot of these discussions that we're having with families. This is what's called the structural equation model. It's very confusing, but I think the most important thing to note is that we did a lot of systemic inflammatory markers. So these are blood markers that tell me that your body is inflamed all the time due to probably chronic stress. And these are kidney-based ones. So these are urine markers that tell me your kidneys are unhappy because of stress. And we thought, are they related to mental health? And is that related to albuminuria? Because the problem we had was that people didn't believe that if we didn't improve your mental health, we couldn't improve your organ outcomes, right? People don't see the link. And certainly we found that there was a significant link from mental health to albuminuria. It just came through inflammation. So kids that had longer durations of higher levels of stress or distress ended up having higher inflammatory systemic markers, ended up having earlier and more persistent albuminuria. And so this leads to that sort of holistic approach to taking care of these kids. The kids that we worked with said nobody is going to understand that and maybe this, and said show them this instead. Tell them blood sugar and blood pressure are important, but also that we knew all along that mental health was important for our biological outcomes. And that includes things like stable housing. And so that is what we have found in iCare so far. We continue to follow these kids now. We did the same thing. We sat and chatted with the kids. This was our first cohort of patient and family advisory group that actually Marilyn ran. Are you in this picture? No, I don't know why. Here's Mary Jane. Again, here's her son Matthew. So they were both part of our advisory group, and we talked to the kids for a while about what it meant to be diagnosed with type 2 diabetes. I think the most interesting thing about this as a physician is you don't diagnose kids with a lot of diseases that they have that much understanding of before you ever meet them, right? And so there's this sort of bearing witness of, I know type 2 diabetes because my mom had it and my grandma had it. These are the outcomes that I've seen in my community related to type 2 diabetes. And so there's a lot of discussions that we have to sort of fix some of the myths, but also deal with some of the trauma that happens right at the beginning of being diagnosed for kids who probably know almost too much from a community perspective. And so there's a trauma related to diagnosis, a fear of the complications that they see, but also a want and a willingness to try and improve the outcomes and get support. We know mental health is important. So these are, anxiety disorders, depression. And so there's a lot of issues in terms of our communities with mental health. And certainly now we're working with psychologists as part of a diabetes team, which is also new for our clinical service and not something that we would have ever had before, right? You have diabetes educators, which are meant to be nurses and dietitians. Maybe you have an exercise person. We kicked out the exercise person. We brought in a psychologist. And so we're learning how to build our programs so that they can help impact change for these kids. I'm not sure that this will, I'm not sure actually that this will play. Oh, maybe it will play but this is one of the videos the kids made to try and help other kids understand stigma. So that's Jenifer. That's our chair of our youth group. That was all their words. That was their script in terms of doing that. And because I was like, well, maybe we can put it on your Facebook pages. And they were like, nobody goes to Facebook. So we're TikToking now. And next step is, I don't know, doing some other kind of, who knows. Okay. So let's see if I can get out of here. The last couple of minutes, I want to talk quickly about Matthew and really what we do in terms of treatment options for these youth. And I think it's important to understand that we don't have a lot of treatment options because type 2 diabetes in kids really is a different disease. And I think that's part of the issue with stigma is that people feel like it's the same as the type 2 diabetes that you get when you're 50 and it's a touch of diabetes. And if only you did lifestyle changes, which equates to lifestyle choices, which often aren't available to these youth, but really that you can go into remission or that you could cure your diabetes. And I think we know that that's not the case. And if anything, it is actually closer to type 1 diabetes in terms of the beta cell failure. So kids who have type 2 diabetes, they have this incredible ability to hypersecrete insulin in the first couple of months. Almost exaggerated to what any adult with the same amount of adiposity and insulin resistance can do. So they hypersecrete, and the thought is that burns their pancreas out because by 2 months out, most of them will require insulin because they just don't have the pancreatic function anymore. That's why we think there were so many treatment failures in terms of the Today study. So this is a United States study of type 2 diabetes in kids. I think what's important to note is although 50% failed at 3 years, 50% didn't and actually did very well, which speaks to the individual nature of type 2 diabetes in kids. And we're still trying to sort out who's going to respond to what treatment tacked when in terms of taking care of them. The good news story, I have 4 minutes to tell you, but that's okay. I saved it till the end. What I do know is that in hospital initiation of breastfeeding, and in Canada, women stay in hospital for 3 days. So in hospital, now I don't know if they continue to breastfeed post-hospital. I know about 60% of our women don't because they have to leave community, come down to Winnipeg to deliver their babies because there's no hospitals in community. And then they have no supports and they fly them back to community. So most of them lose that breastfeeding on their way back to community. But even if you just give them essentially colostrum, it seems to have a protective effect. That's in childhood. And if you follow those same kids out until adulthood, the protective effect decreases because more of them are going to get their diabetes in 30s and 40s, but it's still there. And if you exclusively breastfeed, it's significant. So this is probably the best medicine we are ever going to find for type 2 diabetes. The question is, how do we implement it? How do we make this medicine for families? And I think this is part of me being in prenatal clinics and me as a pediatrician talking to 18-year-old girls who are leaving my clinical service on the last day. My transition discussion is pregnancy, right? I did the same population-based study. This is unpublished, which is why, again, the picture isn't great. But you can see the people who benefit the most from breastfeeding are the kids that are exposed to type 2 diabetes in utero. So this is people who are not breastfed with type 2 diabetes, this dark green line. And these are infants that are breastfed with type 2 diabetes, and the protective effect is significant. It almost drops by 50% in our population in total, with longitudinal follow-up to 30 years. It doesn't seem to do almost anything for gestational diabetes exposure. And so the question is, what is it reversing that kids are seeing in the first trimester? Right now, I care less what it's reversing, I just care it does. And so I'm trying to get everyone on board with this, but part of it is looking at the actual mechanistic reasons why this is happening. Obviously, this is all being done with the kids. So this is Mary Jane and her family, Genevieve, here's Savannah with the pigtails, here's Charlotte, here is the older brother. Actually, this is Anthony, not Matthew. We have a large group. I think Marilyn's in this picture. There she is. And a lot of others. What the kids have told us now is that we need to focus on mental health. So what we've just run is an in-community, traditional land-based programming with dialectical behavioral therapy as part of it, which our knowledge keepers call mindfulness. So we've been doing this for 1 million years. I don't know what your fancy words are. 16 kids was our first pilot. So you can see that there's a bit of a decrease in stress scores and distress scores and a bit of an improvement in our resiliency scores. But we're about to run a much larger trial. This was just to make sure the kids would come and engage. And they do, and they're interested in traditional games and the 7 sacred teachings from their elders that we have built into the skill-based mindfulness teaching. We also did a scoping review with important themes about consulting elders, which are now running our programs in communities. We just really write the grants and fund them, and community members to help with sort of the structural and systemic enablers of health in community. Finally, what am I doing? We're changing clinics. So here's our elder, Sherry Copenat. She opens every clinic in her language with a prayer. We sit in circle, we discuss the goals of the clinic. And then after that happens, they sit and do art therapy with an art therapist to talk about how type 2 diabetes is impacting their lives at the time. And then we do their blood pressures and their A1Cs, and we talk to them as doctors. But this has really improved the care that we're able to give to these children in terms of the way we talk to them. And there's mine saying I'm also out of time. So finally, here's Matthew and Genevieve. This is Genevieve's son, Leo, who's now being followed in the Next Generation Project. He doesn't have diabetes. He does love to come and see us in clinic. Take-home messages really are the importance of context in terms of understanding where people are coming from and living with primary chronic disease. That really we need to join forces, because there is no pediatrics and diabetes care. There's just care and family-based care, and community members will tell you that. And that mental health needs to be a part of the programming, and we all have a role in combating the stigma. So thanks. That's my email. I'm happy to hear from everyone. That's our research website. So it tells you all of what we're doing in Canada in terms of the different projects. And I'm happy to answer some questions if there is some. Here's our team. There's Renae when she came. Oh, look, both of you actually. So we took everybody over to Canada at one point in time to come and work with us up north. I don't know how to look online.
Someone else will tell us.
Oh,
won't they?
okay. I don't know.
Thank you. That was wonderful.
Oh, thank you.
Surely we've got some questions. Are there any online?
Just very clear.
Yeah, amazing. Oh, Anna. Yes. Oh, do we need a microphone so that people online can hear you?
I can repeat it if you need.
Oh, I know you said that we don't quite understand.
Yeah, so the question was why we think that breastfeeding is so effective. So right now we're trying to tease out if it's breast milk that's effective or breastfeeding that's effective. So is it the early contact, bonding, that sort of memory that's built into reducing stress in the newborn period when mom has baby to breast, and some of that sort of rewires us to be able to then cope with the stresses because we have mom there, versus the actual components of breast milk, which obviously are anti-inflammatory and other things. We're looking at, there are some epigenetic changes that we've seen in the kids who are born to moms with type 2 and the kids who we follow in eye care who have type 2. So it's not the same kids. You can't say it's persistent, but it's different than control kids. So there does seem to be some changes in early life. We think those might be reduced or sort of attenuated by breast milk, but we don't have the numbers. That's always the problem, right? We don't have the numbers for that yet. It takes so many kids. We're following about 460 infants right now, and children that we're screening over time. So that's something that will come. Yeah, thanks.
Louise?
Brandy, for an amazing talk. You didn't have much time, but as you put something now, I'm really you're doing now about the elders and traditional games and
Yeah, so it ran in St. Teresa Point, so only one of the communities. And so what we did was they allowed us to use the school. And so right after school, the kids prepared meals with the elders. So they had sort of a snack, and then they went through, so there's different modules of DBT in terms of mindfulness. So there's the ability to turn negative self-talk into positive self-talk, the tolerance of distress, the ability to feel distress, understand it, acknowledge it, and move it away, and the different ways that we call mindfulness in terms of the techniques of breathing or thinking or singing. And so some of that was then built into songs, so traditional song. So when you feel distressed, you can do these things. Some drumming, traditional drumming is an activity that our kids do that they get a lot of strength from. Traditional games, which are sort of running around types of games. And then the 7 sacred teachings. So I can't tell you what I've heard them. That's the elders teach our kids that. And I think that those two things brought together in the two worlds has really been helpful for the kids. And so although it was only 16 of them, there's a lot of them who have said, yeah, I'm using those techniques at home, or, when I'm at home and there's an argument about the diabetes in my family, these are the things that I'm using to help navigate those. So I think that's really great. Our next step is to build that into a bigger program for more communities that actually is incorporated into the 6 seasons. So they have 6 seasons. They have hunting season, fishing season, trap line season, freeze up and break up. And then I'm missing a season. And so they have activities traditionally for all of those seasons. So we're trying to build those into a year-long program for the kids in community for both prevention and to help those that have type 2 diabetes manage it. Yeah. Yeah.
I was just reflecting when you said about your breastfeeding
Mm-hmm.
and how and that say pregnancy, all the interventions that we might be doing there for the outcome of the baby, might have big effects on breastfeeding. So I think about early induction and baby for early. Maybe they're born in a tertiary hospital rather than rural hospital close to home. Maybe there's
Yeah. Yeah, a million reflections. I'm fortunate because I, as a pediatric endocrinologist, have been embraced by our obstetrics and maternal fetal medicine partners and the NICU. So they come down, many get induced, many have C-sections. And so then mom's separated from baby, and then baby's born and maybe is hypoglycemic. And so the first thing they do is they give formula. And then mom and babies are separated. So there's a lot of barriers to breastfeeding right at the outset of birth for these moms and babies. I think there's a lot more we could probably do in terms of interventions with mom and baby together. We have a donor breast milk program in Canada, and they don't qualify. And so you have to be very low birth weight, and you have to be a prem of under 30 weeks to qualify. And so the kids who could benefit so incredibly if mom is unable to breastfeed at the beginning, even the colostrum, unfortunately the regulations where I'm from in our NICUs is that those kids don't get that breast milk. So there's a lot of advocacy and understanding and working together to try and help improve that outcome and take away some of the systematic barriers to breastfeeding. And a lot of moms, like, we give moms breast pumps early, and because it's hard right after you deliver a child, especially through C-section, and then someone shows up with a breast pump and these women are like, are you kidding me? Like, I'm in pain and this is difficult, and I've had a major surgery. And so all of those things that happen sort of prenatally and early, I think, are really important. We have some moms who pump before they give birth. in terms of trying to get a little bit so that when their baby's born and they're hypoglycemic, they get mom's breast milk, even if mom's not with them. So they're starting to look at programming like that through our obstetrics colleagues. Yeah. There's probably lots we could do.
Thank you so much. We had a few questions online as well, but we are at time. So Brandy, thank you. That was wonderful. I learned a lot. I think everybody in the audience, I feel, were blown away with what you shared and the learnings and the work that you guys are doing. So thank you. It's a big privilege to have you here.
Thank you.
Okay, I'm now really pleased to welcome Associate Professor Jackie Boyle to present on her work in diabetes in pregnancy and beyond, a focus on equity in Australia and our region. Many of you no doubt know Jackie. Sorry, Jackie, I've got a few things to say before you can come up. Many of you no doubt know Jackie, who lived and worked as a clinician and researcher in Darwin for many, many years. Jackie is an academic obstetrician gynecologist who now has a clinical appointment at Monash University and is the head of the Health Systems and Equity Directorate at Eastern Health Clinical School. Jackie's research is in women's public health and health services research to improve women's health across the life course, with equity and health literacy, health access and health outcomes as a priority. Thank you, Jackie.
Thanks, Renae. Thanks very much for the opportunity to be here today. I did used to live here for a long time, and I think I started doing my PhD with Louise and Paul actually many moons ago, and I did my O&G training with David Simon in the audience as well. I think it's very nice. I've had a really nice community start to my time in the Northern Territory. I went to the Top Half Folk Festival at Mount Bundy last weekend, which my son, who has subsequently moved back here, was running, and it was such a beautiful community feel, and really, really lovely. So yes, thank you for the opportunity to be here. I would also like to start with the acknowledgement of country and acknowledge the people of the Larrakia Nation on whose lands we gathered today, and pay my respects to elders past, present and emerging. I'd also like to acknowledge the people of the Kulin Nations where Monash University is located, so where I work and where I live, and all First Nations people here and online today. So it's a little bit of a change here. So I don't do a lot of work with First Nations research anymore. There are other people who are doing that, and I don't have First Nations researchers in my team. What I do have is a very multicultural team of people who are largely from Chinese and South Asian backgrounds. And so I'll be talking about our community approach to research and what we've been doing in diabetes with them. And so I will be talking a little bit about the work in pregnancy and postpartum, and I'm going to talk a little bit about the work that we've been doing in Nepal, because that's been a real co-production community approach, and hopefully there'll be some cross-cultural learnings and some future opportunities and challenges. And I'd like to say that I think that doing my PhD here actually equipped me really well to do community approaches to research. I learned so much from working with Aboriginal people up here, and the approach to research and the reciprocity and the importance of listening. And I think that's really enabled me to, we should be doing that with everyone, and it's really enabled me to take that to the work that I'm doing in Melbourne. So what is community? Community can mean a number of things. So this is probably the approach that we take. So it's people with lived experience, but it's also people who are change makers. It's people who have really good social connections and networks and can bring people in to the research. And it's also areas where you can reach people. So that might be health services, hospitals, schools, cultural groups, sporting facilities. And we do engage with a lot of all of those groups in our work. And I think, as Renae briefly mentioned before, there's many levels of having community involvement in research. So it can be community oriented, where they're mostly just consulted. It can be community based, where they're consulted and involved, but there's still quite a bit of external direction and support. And then there's community managed, which is approaching more of a partnership, and then community owned, which is much less common in research generally. And I would say that most of our work is probably community managed, but some would be community based. And there's many different methodologies that can really help in undertaking that kind of research. So yes, data is important, I think, to recognise where you need to work and who you need to work with. But some of the methodologies can really enable you to work really well with communities, such as experience-based co-design, those community-based participatory research approaches, user-centred design, double diamond co-design. They're all really effective in helping you to work with community. So our group does a lot of other things apart from diabetes, but we do quite a bit of work in diabetes, and really trying to focus on that human-centred and equity approach with community engagement and co-design, and thinking about that socio-ecological model of health, because we know, I'm talking to converted here, but we all know that it's not about individual decisions and actions. There's a whole environment around people that's affecting how they're able to make health decisions and take health actions. So we're based in eastern Melbourne. It's an area that covers 2,800 square kilometres. Now, I know that's not very much in the Northern Territory, but it is the largest health area in Melbourne. We have a third of people who are born overseas, and a third of people speak a language other than English at home. But then we also, I think, in terms of thinking about our equity, we also have a number of groups of people who, they're small numbers, but they have very low proficiency in English. So people who, for example, who speak Khmer, Hakachin. And so when we're doing research in our hospital, we need to be really aware of that. So, for example, when we recently started remote monitoring for glucose monitoring for women with gestational diabetes, we really had to make sure that we had some resources for some of those languages where we don't readily have interpreters, and they would not be able to really understand what we were doing without having some thinking about the resources we need up front. We do different kinds of work. So some of it is very centred around the Eastern Health region. Some of it is more state and national based. And some of it as well has been international, both in projects internationally, but also working, for example, with an international reporting guideline, in precision medicine, which I'll mention briefly at the end. So in trying to keep it person-centred, some of the work that we've been doing has been looking at who's most at risk of gestational diabetes in Australia. What programs work and for who, what do women and their families want, and who's accessing care and who's missing out. So I'm just going to briefly talk about some of that work. So we have looked at, we had a PhD student who has been mapping gestational diabetes in Australia. So he looked at it by state and territory, also by socioeconomic status, by ethnicity, but also by statistical area level 2 using the postcodes of the participants. And he's done some other work also looking at some of the environmental factors that we know are important in gestational diabetes. So that includes things such as air pollution, temperature, looking at whether access to fast food outlets and whether your environment is walkable and conducive to physical activity, all of those sort of things. Ooh. I don't know what happened. What he found was that, we all know that gestational diabetes is increasing across the board, but then the two groups that it was increasing most in women who weren't born in Australia were people from Southeast Asia and South and Central Asia. And not surprisingly, as we all know, people who are from lower socioeconomic areas that experience socioeconomic disadvantage are also more at risk. And that risk is interconnected with some of those other things that we looked at. So, for example, areas that had high access to fast food outlets, the people who lived in areas of socioeconomic disadvantage experienced more gestational diabetes in relation to those factors. Yep, oh, actually, wonderful. Thanks. I'm sure it wasn't me. I have a bit of a thing. My PhD supervisor used to say I was cursed when it came to IT. I think I've just proved that hypothesis. So yeah, those top two lines are people from South and Central Asia and Southeast Asia. And certainly where the area where I work, there is a very high proportion of Chinese people. So a lot of the work that we do in focusing on gestational diabetes and postpartum in the Eastern Health region is focused on women from Chinese backgrounds. And yeah, that just also is what I was just mentioning about that interaction between those socioeconomic factors and other things. And if you look at over time, so the first, so this is by 2 years, over 2 years from, so once the first one is 2016-17, next one is 18-19, and then 2020 and 2021, you can see, and we kind of thought this was really important to do for thinking about health policy and thinking about where are you going to focus your health promotion and your health care, but also recognising who lives in those areas. And in those hotspots, so the red areas are hotspots, and they really map quite closely with where migrant people are living in Melbourne. And the bottom one is Darwin. So we did this for all the capital cities, and there certainly are pockets where you can see them growing over time. And yeah, as I said before, environmental factors can also be important and is probably going to be more relevant going forward with all the factors with global warming. So what works and for who? So we also looked at, we did some systematic reviews looking at what works to prevent type 2 diabetes after gestational diabetes. We're always wondering, when do we start interventions with women postpartum? And there wasn't really much difference across that year postpartum, but it was important that it started in that first year after giving birth. They were also more effective in women who had a baseline BMI of 30 or more, and more effective if they were based on behaviour change theory. And for body weight reduction, it was effective if there was a BMI of greater than 25 or if there was electronic delivery included. So that all sounded really good. But then we had a look at who was in these trials. And we used the Progress Plus from Cochrane. And so that includes things like where you live, your religion, your occupation, your gender sexuality, your education, social capital, disability. So most people did not report on any of those criteria very well. Socioeconomic status was one of the ones that was probably, that was done about a third of the time, whether it was urban or rural was reported about a third of the time, and of those 50% were urban. And then there was no studies in low-income countries, which, if you think about where diabetes is also really increasing significantly, both in Africa and Asia, there was no work done there at all. So I think we just always need to be mindful of those things when we're thinking about interventions and how they can be applied in the real world. Are they applicable to the people that we're working with? So building on that, we then partnered with the LIFE program. So this is a diabetes prevention program that's run by Diabetes Victoria, and it's free. So anyone can join who's at increased risk, and women who have had gestational diabetes can join. They used to have to be referred by a health professional, but more recently, partly to get around, I guess, some of the lack of engagement, they can actually refer themselves now. So when we looked at the who was actually starting the program, around 3% of women who had had gestational diabetes were actually engaged, even started the program, and of those, about 55% completed the program. And those who had the greater completion rates were those who lived in metropolitan areas, those who had a healthy BMI, remembering that the people who did better on the intervention programs had a BMI over 30. So for some reason, they weren't completing this program. those from middle income. So we're not really sure why that was, whether high income people potentially are accessing other services that they can pay for, and not sure why people who experience socioeconomic disadvantage were less likely to. And that's clearly work that we need to do ongoing. And then people born in South or Central Asia were less likely to complete, and we know that they're at highest risk. So that's also an important area to address. The Chinese women actually had a reasonably high completion rate, and probably because they had some really excellent Chinese facilitators who went out of their way to really engage with women in between the program. So the program there's 5 sessions every 2 weeks, mostly online now, and then they have a check-in at 6 months and 12 months. And the Chinese facilitators really made it culturally appropriate and linked in between times. So I think, shows that we can improve things and make them appropriate for everyone. But of the women who did participate, they certainly did have an improvement in, or who did complete rather, they did have an improvement in their weight, their BMI, their waist circumference, increased physical activity, and improvement in their dietary fat and fibre score. And the rural women who did complete it also had good outcomes from those point of view. So if people complete, they did quite well. So we need to look at how we can improve completion. So we did do some work with South Asian women and rural women who had been a part of the program and looked at what they were looking for and what could be improved. And it's really not dissimilar to some of the First Nations approaches, I guess, to diabetes and health. So family-centric, they believed that health was more a family-centric approach. The mother's health was considered a low priority. Her role was more to look after the family. They wanted more integration with community activities and more culturally appropriate health advice, including follow-up and referral pathways. So, they all said that there's a lot of focus on their gestational diabetes in pregnancy, and then once they have the baby, it's like, see you later. No one talks to them about what happens then. And also thinking about integrating it with cultural settings and events. For rural women, some of their things were the same, that there was a low priority on the mother's health, but also that some of them thought that they knew enough about healthy lifestyle. And in terms of the health system, that there was limited general practitioners and awareness to refer them. So hopefully some of that has been avoided now that they can refer themselves. So then we wanted to really understand, do a bit more of a deep dive into what women's needs were and how could we develop community solutions. So this was encompassing, partly related to the LIFE program, but also because we wanted to really improve what was happening through Eastern Health as well. And we partnered with both the LIFE program, but also with some of those other partners that we had, so Women's Health in the East and the East Melbourne PHN. So I think the thing that was really striking about these partnerships was that we had done some work some years ago with Chinese and Indian women where we did some qualitative interviews. And we found it, and we hadn't really partnered with community so much at that point. And we found it a bit hard to recruit women. So we were doing it through the National Diabetes Service. And our findings were that their barriers and enablers were to accessing postpartum screening and prevention were not that dissimilar to other Australian women, which was a bit surprising, and I think probably because we hadn't really gone about it in the right way. So this time we had absolutely no problem recruiting women, and we were really looking to dive a bit deeper there. So we did a number of different things. We did interviews, and then we did a co-design workshop, and that included health professionals, which were midwives from the health service, also from primary healthcare and from maternal child health, as well as with the LIFE program developers. We also looked at analysis of the resources and then did another co-design workshop. And these were the questions that we asked. So it wasn't really around barriers and enablers. We were really trying to understand concepts of health and well-being, and it really did bring up some completely different results to how we had approached it previously. And it was a very iterative process. After each interview, we reviewed what we were doing and looked at what had come out and reviewed and changed some of the questions. And then we had to kind of then restart again once we started with the South Asian women, and we're now doing white European Australian-born women, and the questions are actually almost quite different again. So I think similar to other community, it's really more community-based. It's not about you as an individual. It's about having harmonious relationships. That's what health means to people. There was also quite a bit of discussion around traditional and modern health advice. And whilst it's really valued, that traditional health advice and beliefs around, for example, for Chinese hot and cold food, for that really resting for that 40 days after giving birth, some of it, conflicts with what we're being told by conventional medicine. So it's trying to balance those things and recognise, for example, which traditional practices are not harmful but can still be important and incorporated, and how can we merge those two. And one of some interesting things that came up, for example, from the South Asian women were that packaged food in some of the dietary advice was really misaligned with their cultural food preparation, where they're really, they do things from scratch. So they're not really using packaged food. So that really didn't speak to them, apart from obviously the fact that a lot of the food was completely irrelevant to them. And then they also said that talking about strength training was not really applicable because they associate that more with masculinity. And so you have to think about how do we reframe that so it's more acceptable to women. And then we had different viewpoints. So some of the positives about gestational diabetes was that women did say that it could be a turning point. But then a lot of them didn't also consider that diabetes long-term was necessarily a significant risk. Most of them said that managing their diet and physical activity as they had been trying to do during pregnancy was just not sustainable in the long term, and that we have to work out how that can also be done in a way that's not too onerous for them. And stigma was, so I know that in this group of Chinese women, stigma was not necessarily raised, but we have done some experience-based co-design work where it's been a big factor. And they felt very much that there's, particularly for women who have a higher BMI, that they felt very stigmatised and that gestational diabetes was really their fault. So I think, we always need to be not just accepting what one lot of research says, but, keeping on investigating and finding out more. But yeah, there were some really quite distressing quotes from some of the South Asian women around feeling that it's a tragedy and really a personal failure. So we really need to look at having some more positive messaging. So with the co-design prompts that we had, these were looking at culturally appropriate resources, those traditional versus modern practices, the social stigma and misunderstanding, mental health challenges, and that has come up as well in quite a lot of research that we've been doing. So we also did some work with both women with lived experience and health providers across Africa, Asia, Oceania and the USA. And it was really interesting that, as Brandy referred to, the women were all saying that mental health and their social connectedness and wellbeing was one of their highest priorities, and that they couldn't really look at any prevention activities without that. And a lot of the health providers were like, no, that's not right. And, as the moderators, we had to say, well, actually, you have to listen to what the women are saying. And then the dietary and lifestyle barriers. So, I mean, there was a lot more results. These are just some of the brief ones. around developing culturally appropriate resources. For a lot of the Chinese women, for example, particularly because a lot of them don't speak English and the supermarkets are completely overwhelming and they find it hard to find food that they know is suitable, and they don't know if they're not buying more cultural food, what food's good, what food isn't. Addressing some of that misinformation. And they all actually felt that they really needed to hear from other women who had experienced gestational diabetes in their experiences after pregnancy, and also their experiences with the diabetes prevention program. And again, for the South Asian women, very similar, but they felt that language needed to not be don't, but to maybe limit, do your best. Think about vegetarian and halal food options for them, because a lot of our resources don't include that. And then they had slightly different ideas about boosting visibility of prevention programs. And the Chinese are very connected through some of the social media platforms, and we've been able to use them quite effectively in recruitment and dissemination of research. Whereas the South Asian women were more about some of those in-person opportunities. So I think the impact of working with these community organisations has meant that we've been able to increase our reach. It's really facilitated recruitment and enabled deeper understandings beyond those traditional barriers and enablers to accessing care. It's improved awareness and referral pathways for the LIFE program, and we're looking at expanding on a program that we've got where we have been putting in information packs in women when they leave hospital that has included things such as some general breastfeeding and where to go for support, such as pelvic floor training, and where they should look online and where they can go for support. And also thinking about contraception and mental health. And so we're looking at now including some of those things for gestational diabetes. We're also running some workshops with the LIFE program, so in those hotspot areas. So not only for community, but also trying to improve awareness for health providers. And I think that also when we audited the LIFE program, you know, you don't know what you don't know. And so working with them to look at how they can improve their monitoring of who they're working with and what their results are will really help them in identifying that they're reaching who they need to be reaching. And we're now working with the East Melbourne Primary Health Network, Eastern Health and Maternal Child Health, and various other community health organisations who provide things like community art activities or pram walking groups and things like that to develop service navigation tools where it's an online tool where anyone can access it, and it will tell you where something is, how much it will cost, what language are things offered in. So just to make it much easier for health providers and for women to find things that will support them in that broader support to help them with their well-being. And then we've recently put in a grant around social prescribing, so hoping to trial having a link worker to also work directly with the women as soon as they've had the baby and see whether that can be of benefit. I also just wanted to, so this is actually not in pregnancy, this is a project that we're doing with adults from 30 to 60 years of age in Nepal. So we're doing it in 3 municipalities. So that was very cute. Not happy that I'm moving on from pregnancy. So one is a municipality in one is a municipality on the map in Bhaktapur, one is in Kathmandu, and one is in Pokhara. Each of those municipalities has 9 wards, and within those wards, there'll be a hospital and some either primary healthcare units or health posts. And the reason that we're doing this work is we're trying to improve both diagnosis and management of diabetes and hypertension. So in Nepal, around 75% of diabetes is undiagnosed, and about 6% of those who are diagnosed are on treatment, and is increasing quite rapidly across Nepal. And similarly for hypertension, about 60% are undiagnosed and 20% on medication. And very few, around 10%, achieve their nominated targets. And again, those who are in the lowest quintile of income earning are the people who are least likely to be diagnosed or to have good control. There was a trial so this is Rashri Thapa, who is one of the Nepalese researchers in my team, and her PhD was part of her PhD was doing a 5-year evaluation on a trial that had screened people and given them some support over a year. It was a randomized controlled trial for diabetes and hypertension, and their outcomes were better at 1 year, and at 5 years they were worse. So there's clearly something that's not right there. So we're really trying to look at how we can improve that over time. So it's been a tricky process, but I think this really has been quite a co-production event where we're working with the Nepal Development Society, with the Ministry of Health, and with mayors and ward chairs of the 3 municipalities. And you always put something in to get grant funding, and you kind of have an idea, and then you say you're going to co-design the details. Well, yeah, that's definitely happened with what we're doing. We're definitely redesigning and co-designing. But it's been fantastic because we've really had engagement from all of these. We had one of the ward chairs I was sitting there on this 2-hour meeting with my AI translator from Nepali to English, and it's not a common language, so sometimes it was a bit strange. And it said that this ward chair, they said that his brother died last week, that he was still here. And I was like, that can't be right. And then I spoke to people afterwards and said, no, that was actually what he said. He just felt so strongly about this, the importance of heart disease and diabetes, that he really wanted to be there and to support this work. So our plan was to do a similar screening to what they did the previous time with the female community health volunteers, where they would do blood pressures and blood glucose checks and then follow up over time. But they're paid as an incentive, and they're not necessarily always regular. I think the municipalities that we're working in have kind of moved a bit away from that. And they really want to take ownership of it a bit themselves, which is great because it means it's going to be more sustainable. So now we're going to be working with them to do that. We've also done some service availability and readiness of all of the facilities. We've done over 100 interviews, and we had about 60 people at each of our co-design workshops. So it's been really fantastic, but it has meant that we've really completely changed what we're doing, but in a better way. And then we ended up having lots more questions for the advisory committees as we went on, and I'm being told to wrap up. So I'm going to just move along because I just wanted to actually really show you the video from there. Maybe. Or maybe not. I'm just going to stop it because I think I'm running out of time. But yeah, just to give you a sense of some of the complexities of what we're working with, and apologies, I think people online couldn't hear it, but there were subtitles. I think I just wanted to finish with was some challenges and future priorities. I do think that broader environmental work is going to be really important that we think about in diabetes. And whilst I think it's really great that there's precision medicine coming, I was at a precision public health conference recently, and there was a lot of wow factor about all this technology, but I think we need to be really careful that we don't lose community and the people at the heart of health. We really need to make sure that they're being brought along with that. And we were involved in the guidelines for the Be Precise checklist, where we brought in some community people and organisations, but it's really, we just need to be really careful about that. I'd like to thank all of my team and community partners and participants, and thank you.
Thanks so much, Jackie. I'm sorry that we've supported your PhD supervisor's theory that you're a bit cursed with technology. We had a few fumbles there, so I'm really sorry, but you did very well. You managed very well. Thank you. That was a really insightful sort of overview of work that's related to what we asked you to speak about. And I think it highlights the breadth of your experience now across the globe. And there are many learnings for us within our space here across Northern Australia. And I think one thing that I was reflecting on while you were talking is the work we've been doing in our diabetes and pregnancy co-design space really has so many similar synergies with what you were talking about in terms of the need to pivot. We come in with these preconceived ideas, even they might be based on recommendations we've had from research and people on the ground, but it's not until you get back on the ground with people who are living with these conditions that you really need to rejig some of your thinking and often shift from being disease focused or diabetes focused to being well-being focused. And what does that mean? What does that look like? We do have a couple of questions. We've got one online. We neglected our online participants before, not on purpose, but because we ran out of time. But one question that we had was from Kate, who asked whether or not the GDM prevalence data maps are published or available online.
They're under review, so hopefully published soon. Yep.
I can open up for some other questions if there are any. Matt? Or we just have to make sure the ceiling mics are on before you. Thank you.
Thanks so much, Jackie, for that presentation. Going back to the recent part period after the GDM program, a lot of conversations take place briefly around program like the efficacy of those sorts of things, right through to other options like pharmaceutical management, about their trials, those GDM, those GLP-1 injections, for weight loss, a lot of people that purpose. Take your thoughts around kind of individual level approaches with legal support programs to do with or
yeah, I think if we think about well-being generally and after pregnancy, that I think it's probably more than one thing. And I think that, we do need to think about mental health and well-being, all of that social connectedness and the diabetes prevention. I think we need to stop being in silos so much. And so I think we need to not just jump ship and go on to medications as well. I think it needs to be broader than that. Having said that, we're doing some work in Malaysia, and everyone is really worried that it's too late for diabetes prevention after gestational diabetes because the risk of type 2 is so high, and they all want to put metformin in the water. And we have actually we've put in for a grant to look at doing a trial looking at those options. So not for GLP-1 because they're not affordable, but for metformin and lifestyle prevention, because yes, it's tricky. So again, I think, yeah, we need that, possibly will be part of an answer, but I think we need to also not lose that person-centered approach as well if we do end up using medication.
There's another question online, Jackie. The shortage of medications is a big problem. Is the government committed to projects?
Is this in Nepal?
It's not. They didn't.
So yes, the work in Nepal, there is, well, I suspect it's in relation to that one. And yes, there is a shortage. So there's a shortage of medication. That's partly why people weren't going to the health services, but that's why it's been really good to have such strong local and national government engagement, because they're the ones who control procurement, and they have said that if we tell them the numbers that we're screening and how many people we expect, that we will see, but they've said that they will guarantee that they will have. So they have certain medications that are available free. So it's not all medication. So for example, amlodipine and metformin are the two most common, but they have guaranteed supply if we liaise with them about the numbers to expect and what we think they might need. So I'm hoping that engagement and partnership will mean that that does work.
Thank you. I think we'll wrap up there. I understand morning tea is ready. Thank you all for participating in this morning's session. We will be back in half an hour to reconvene. So enjoy your morning tea break. Thank you.